You're listening to Medscape's In Discussion series on psoriasis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Stephen R. Feldman, Professor of Dermatology, Pathology, and Social Sciences and Health Policy at Wake Forest School of Medicine in Winston-Salem, North Carolina. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hi, I'm Dr. Steve Feldman, and welcome to Medscape in Discussion. Today, we're talking about psoriasis and the most important thing to know about psoriasis treatment, using topicals. First, let me introduce my guest. She's a dermatologist, an assistant professor at Queen's University, Ontario, and she serves as medical director at the Skin Center for Dermatology and the Skin Research Center. A prolific researcher, she's published about 100 Medline referenced articles on psoriasis, as well as psoriasis treatment guidelines. I'm honored to present Dr. Melinda Gooderham. Welcome.
Thanks, Dr. Feldman. Happy to be here.
Let's just start off with some fun fact with our listeners that people just don't know about you.
I guess it's fun for me because I love to travel the world, and this job being a dermatologist who does clinical research has given me the opportunity to travel all over the world. And I actually filled a 10-year passport in 4 years.
That's awesome. What were some of your favorite places?
Israel, amazing. Taiwan, amazing. Every place has such a different thing to offer. Any place in South America. I love food and I love drinks. So anywhere I can go to try something new is open to me.
That's great. Dermatology has been very good to me too. I think one of my favorite places that dermatology took me was Iran. Have you gotten to go to Iran?
No, I have not been there yet.
The food there, you will enjoy it. I hope you get the chance. All right, let's move on to psoriasis. What is the role of topicals in psoriasis?
Yeah, topicals play such an important role for the whole spectrum, whether you have mild disease, moderate or severe topicals will definitely play a role for localized disease. So in a mild patient who has 3% or less BSA, our first line of treatment is going to be topical therapy. But then we have the moderate to severe patient who, although topical therapy may not be most practical, we're going to use some systemic therapy, but we're going to combine that with topicals.
What are some of the challenges of prescribing topical treatments?
Probably the number one challenge, which you're well aware of, is patient adherence, because you can have the most you can have the most amazing topical, but as I tell my patients, if it's sitting in your cupboard and not on your skin, it's not going to do anything. So that's the main thing is getting patients to apply the topical, and there's so many factors that affect that.
There's a lot of topical options too. Is choosing topicals, is that a challenge?
Yeah, that is one of the issues that again factors into adherence, is so many factors such as the vehicle that the topical comes in, where on the body you can apply it, the cosmetic acceptability of the product. Even in patients with limited disease, if they have a number of different areas involved, special sites that we call the face, the scalp, the groin, they'll all need a different topical to use. So the more complicated the regimen is that you give the patient, the less likely it is that they'll be able to follow that.
Okay, so let's give some brass tacks advice. If you got a patient, they've got elbow and knee psoriasis, what kind of topical should we be thinking about prescribing?
So for the body, sort of first line, our cornerstone management, topical corticosteroids. I think one thing for our listeners, if we have a wide range beyond just dermatologists, primary care, is that body psoriasis needs a potent or super potent topical corticosteroid. And so giving a topical steroid that's not strong enough, the patient will get frustrated. They'll sort of lose faith in the treatment. And so I think that's one important takeaway for body, elbows, knees. You need something potent or super potent from the steroid class.
So something like a clobetasol or a betamethasone?
Yeah.
And then are you prescribing a cream or an ointment for those patients?
It depends on the patient really, and sort of the discussion you have with them about what they're willing to apply. Again, it gets back to what will the patient use? Some patients prefer an ointment, some don't. They find it too greasy. But I have to say, for my own practice, I actually use a lot of combination products with a potent or super potent topical corticosteroid. So betamethasone dipropionate mixed with either calcipotriol, or you could have like a halobetasol mixed with tazarotene. And I find that a combination product, when you want something potent, offers some other advantages like improved efficacy or reduction in side effects, whether it's irritation or skin atrophy. Some of the combination products sort of check more boxes on the list.
Okay, so we got moisturizers to use for dry places, corticosteroids, the potent ones. I presume milder corticosteroids for face and genital area. You mentioned having vitamin D and vitamin A analogs so that we can use. Any other topicals we should be thinking about?
Currently, we have some off-label use. We have topical calcineurin inhibitors, although they're approved for atopic dermatitis. We often use them in the sensitive areas, as you mentioned, the face, the groin, the folds. Tacrolimus, pimecrolimus. We will use off-label crisaborole, which is a PDE4 inhibitor. They often play a role in our management at this point, but looking to the future, we're going to have some more options that are not steroids, where we won't have to use multiple different agents for different body areas.
One of the treatments that I used to recommend a lot before we had so many options was topical tar. And now I've started coming back to it once we learned about aryl hydrocarbon receptors.
Yeah, actually, I just compounded something with LCD the other day for a patient because they were, reminiscing of their older dermatologist used to give them some tar products. The problem with tar is the odor, the messiness. So with the aryl hydrocarbon target with tapinarof, we're going to be able to have that efficacy without the downside of the odor and the messiness that tar brought us.
And just for those who don't know what LCD is, do you mind?
Oh, sure. Liquor carbonus detergents. It's an extract from tar that makes it a little easier to use than actually slapping on tar.
Yeah. If you had a new patient, what would you ask them regarding that would help you decide what topicals to prescribe for them?
I like to find out what they've already tried before, sort of have the same conversation. Was it a white cream? Was it a greasy ointment like Vaseline? And they'll often tell you right off the bat, the last treatment I used was too greasy. It got all over my sheets. It got all over my clothes. And so, right away, those patients are not going to tolerate another ointment if you give them that. So one other thing that has been, over the past decade or so in the psoriasis topical treatment landscape has been new vehicles. So we've had topical corticosteroids for years, but in the past few years, we've come up with different ways of applying them to sort of improve that adherence that's such an issue. So things like foams, sprays, optimized lotions that don't leave that greasy feeling, because that's one of the deterrents for adherence of therapy.
The sprays make a difference compared to the ointment?
If the spray is made properly, and you can get some improved absorption with sprays, I find they do need to have some sort of either combined with a moisturizer, or some formulas have sort of a moisturizer built into it, but we do have this dry scaly plaque. So if you spray on a solution, you may not be able to help with that scaling as much as an ointment, which is a bit more occlusive.
I tend not to prescribe a moisturizer with the spray because I'm not so sure you really need to moisturize anymore. You look at the spray studies, and I don't think they incorporated a moisturizer in those studies. I think they just let people spray the stuff on.
And once they start working and you control the inflammation, you're not going to be producing more scale. But if a patient's complaining about the dryness or the cracking or whatever, I will recommend a moisturizer, but it's not part of my regular routine. The spray I use actually has a moisturizer as part of it, so it's not much of an issue. The only problem I will say about a spray is it's almost too easy to use. So I find that for the most part with an ointment, obviously in the back of my mind, I'm always worried about side effects and atrophy and things like that, but I just don't see it because I think people aren't adherent enough. But when you give someone an easy to use spray, they tend to use it quite a bit. And then that's where I start to see some atrophy showing up, because it is so tolerated. They're a little more adherent.
Are there particular settings where you tend to see those atrophy side effects more often?
Well, if they are using them in more sensitive areas, you give someone a spray for their knees, and then when they notice something showing up in their groin or in the axilla, they may just start to use the spray there, even though you may have told them at their visit to put it on a sensitive area. Sometimes patients forget, and there may be a time lapse between the last time you saw them and when they are developing new areas. So for sure, in some of the sensitive areas, you can see more atrophy, but I have even seen some elbows and knees with excessive steroid use showing some atrophy of the skin, telangiectasias.
I think we have to worry when we see patients, certified public accountants, architects, engineers, anal retentive people, the kind of people who bring you these multicolored Excel spreadsheets showing you everything they're doing. Because if you tell them to do something twice a day, they might actually do it. And if you don't give them a stop point, maybe they would develop atrophy more often.
Yeah, I'll never forget the one case in medical school before I was even in dermatology of a woman who came in with basically bilateral black eyes, and she'd been applying clobetasol to her face for many years. And, amyloidosis was even on her differential with her presentation until we found out it was actually the clobetasol she was using on her face.
Patients do the darndest things. So do you have any tips, tricks, general approaches you use to educate people about the use of their topicals?
I mean, I do tell them it's important to really, stick the course for the first month or two and make sure they are putting it on every day while there's still some visible lesions there. But since we've had some studies like the So Long study that told us once the skin is under control, you can go down to a reduced application. So maybe twice weekly for maintenance. So I try to counsel them on that. Use it every day for a month. We really need to get control of it. Don't stop too early. But then once it is under control, back off a bit, twice a week ongoing for maintenance.
If someone came in with limited scalp involvement and you thought topicals were appropriate, would you give that same advice? You change it in any way?
Yeah, pretty much similar advice when some of the topical oils, sometimes it depends on their insurance and what's going to be covered. We have to work with what we have access to. So there are some topical scalp oils, oily gel that will apply. We can use a spray in some of these areas, and then I will try to get them to use it on a regular basis. If it's really localized on the scalp, sometimes patients get very frustrated with washing out product from their hair. And there are some times where I may even use intralesional triamcinolone in a very localized plaque.
Yeah, very good adherence with intralesional
Yes.
therapy. I would tell patients, I think treating the scalp with topicals is like the mother of all adherence problems. So I try to keep that treatment exceptionally simple. And instead of telling people to follow up in a month, I encourage them to follow up in 3 days. Because I figure if I tell them it's just 3 days, well, if the dentist told me, I'm worried about your teeth, Steve, I want you to floss every day, I'm going to see you back in 3 days, I'd probably floss really well those 3 days.
Yes. Yeah. More frequent follow-ups, definitely, when, scheduling allows it. And, I've even tried some ways with following up with the nurse if I don't have room in my schedule. So they know that there's some, accountability to somebody, because we find that with clinical trials. And I do say that to patients in my general clinic. I'll say, when we use this in the clinical trial and patients came every week and we weighed their tubes and we, watched how much they were using, I said, it really worked well. And, you have to think about use in the real world. I said, going away for the weekend and not bringing your topical with you, or, staying over at a friend's house and forgetting it, or just taking a day off here and there, you're not going to get the same results.
Yeah, I think people do use the medicines better in studies when you bring them back every week to follow their progress than when you tell them, see you in 2 or 3 months. Okay, accessibility of some of these things is an issue. I love the spray because some people find it so easy, but where I am, the spray is often more expensive than the clear liquid. One of my favorite tricks to share is to just order the generic solution, get a spray bottle at the dollar store and put it in the spray bottle and you're good to go. You have any other tricks for making sure that the treatments are affordable for patients?
Yeah, it is very tricky. And I know it's a bit of a different landscape in the States compared to Canada. We're having some generics available. So there's some insurance plans that will substitute the generic, which is, great if that's what their access is. We also do try to work a bit with some of the companies on a compassionate use. So if somebody doesn't have insurance, we'll be able to get them some access to some products. But as I mentioned earlier on, I like to use a lot of combination products, but these are typically more expensive. In those patients who don't have insurance, who are paying cash, I will often go to a generic steroid with a little more advice on how to use it properly. And to be honest, one of the reasons I got into clinical trials in the first place was to help patients access therapies through clinical research, and that's been rewarding.
I have the sense that when you choose a topical therapy for somebody with limited psoriasis and they don't get better, it's probably because they didn't use the medicine, which makes me wonder, are the new topicals that are in development for which there's so much enthusiasm, are they really going to help? Because the only people who are going to get them are people who aren't putting on their topicals.
That's a great point. I mean, what I'm hoping with the new topicals is some features that might make it easier to use and easier to stick to the plan. So topical corticosteroids, BID application or twice a day application. The newer non-steroidals are once a day application. So that will help. Number two is the fear of side effects with topical corticosteroids, because even if you counsel a patient in your office, I'm not sure if it's the same in the US as in Canada, but by the time they get to the pharmacy, sometimes the pharmacist scares them with, you can't use this for more than 2 weeks, but this is a chronic disease. And once it's 2 weeks is over, of course, they still need to use it to some degree. So they're not using it because they're afraid of the side effects. With the new topicals that are non-steroidal, there won't be the same atrophy. There's not the same tolerability issues that we might see with topical calcineurin inhibitors, such as burning, stinging. So that will be also one feature that will encourage the use. They won't have to feel guilty every time they use it. Then there is the speed of onset. Steroids do actually work quickly, but some of these new treatments also, you see that benefit early on, and that's also encouraging for patients to stay on. As I mentioned earlier, if you're using a steroid that's not strong enough, like for example, if in primary care, if they're a little reluctant to use a more potent topical steroid and they give them, hydrocortisone or something, they're going to put that on. It's not going to help. In the patient's mind, steroids aren't going to work for them, even though they've only used a very mild steroid on their psoriasis.
You mentioned primary care. And I think primary care docs are at the forefront of seeing these patients. So many people with psoriasis out there who probably never get to dermatology. What other practical advice do you have for primary care doctors seeing patients with psoriasis?
They've got a lot to keep on top of. They've got diabetes, they got hypertension, they have all these things that with all new medications coming out. So I know it is a challenge, but I guess my advice would be to sort of keep up on, with something like Medscape or podcasts or however you like to get your education, but keep up on what's new. The other thing that I think the most common, I'm not saying mistakes, but the most common downside is not using the proper topical. So one that is too mild, which, as I mentioned, can affect adherence because then patients lose that confidence that this is going to work. Not being so afraid of the topical steroids that your patients are fearful to use them. That frequent follow-up that you mentioned, I think is really important for adherence of therapy, because that's all going to relate to the success of the patient. And finally, if they are not responding to topical and you're sure that there is proper adherence, then referring them on for systemic therapy, because instead of calling mild or moderate to severe, we're now starting to make the division of topical responsive and topical non-responsive. Like who deserves a systemic therapy for psoriasis is when you fail topical therapies, but we need to make sure that it was an adequate trial on topicals.
New patient with psoriasis comes to the primary care doctor, psoriasis on the elbows and knees, betamethasone dipropionate cream or ointment, whichever the patient would be willing to use.
Very reasonable.
If there was some scalp involvement, a little bit of fluocinolone solution or an oil product if they were willing to put an oil on.
Yep.
Okay.
Trying to keep it simple.
Yeah. And boy, they're always telling me to ask my psoriasis patients about joint pain. We'd probably tell the primary care doctor to do the same.
I would. I find every time I give a lecture to primary care providers about the systemic inflammation of psoriasis patients and the associations, 1/3 of psoriasis patients having psoriatic arthritis, I get a flood of new consults. Every time you give a lecture for about 2 months, you get an influx of all these consults, and then they quiet down again. And then, it's reminding again, these patients do have other comorbidities that we need to. So not just joint pain, but other factors, cardiovascular disease, metabolic syndrome, and other comorbidities that these patients might have.
All right. Any advice for us dermatologists about how to improve the topical outcomes of our psoriasis patients?
Same principles, stay up to date on what's available on the new vehicles. And I know we're all busy in our clinics, but even if you can come up with some system with your patients to have a touch base, whether it's in the clinic or not, touch base with your patients a bit earlier.
Yeah, I think that's excellent advice. I give patients my cell phone number and tell them, call me this weekend. Let me know how it's doing. I think that lights a fire in them to fill the prescription. All right. Any other most important idea you want to pass along to our listeners before we wrap up?
Educating yourself, understanding the different strengths of topical steroids in primary care, even if you just pick 1 or 2 in each potency, just so you know where to go. And keep a little cheat sheet in your office. I have a lot of residents who come through and they make these little cheat sheets. Know what the different vehicles are and know what is available through insurance. That's one other problem, giving a patient the prescription that they're not going to be able to afford, and then they get to the pharmacy and then they're too embarrassed to tell you they couldn't afford it. So making sure you understand what is accessible for that patient and what they're willing to use, because the best treatment is the one they can access and the one they're going to use.
Great. Okay. So a little hydrocortisone cream for the milds. Be comfortable with triamcinolone 0.1% for intermediate, and then have a betamethasone or a clobetasol for the higher. Lastly, tell us about one of your mentors and the best pieces of advice you got from them.
Oh, so many mentors and so much advice. Probably you remember Stuart Madden.
Very well.
Legendary Stuart Madden, amazing, trailblazer in Canada. Probably one of the first dermatologists to use a topical steroid. Actually, he'll tell you about grinding up the adrenal glands and going to a conference in England in the 50s. It was amazing. Amazing to his stories. But, he once told me to, he didn't use the word burnout, but he knew even back then. He said, you can't do 5 days a week of patient care for the rest of your life. He said, you need to find something else, whether it's research or whether it's medical education. You need to have something else to focus on, and that will keep you happily treating patients. And I think that's the best advice that I've had from my mentors.
That's great advice. Yeah. Preventing burnout is something we all should be paying attention to these days. All right. Well, we've got topical steroids for our patients with psoriasis. There's non-steroidal agents that can help. I hope you've enjoyed today's program. This has been Medscape in Discussion. I'm Steve Feldman. I hope you'll join us again next time. Thank you.
Thanks for listening to Medscape's In Discussion Psoriasis podcast series with our host, Dr. Stephen Feldman. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on psoriasis.